Good morning. Today we will cover the next topic, the strabismus. Actually, this was to be covered by Dr. Munish. I am taking on his behalf. Okay. So, what is strabismus? You have all studied in the previous lectures. In the previous lectures, you have all studied these tests, muscles, anatomy. Now we move bit. Now we move to a bit of the clinical aspect of strabismus. Okay, and as a clinical aspect of strabismus, we have to remember. For example, usually we see an object. For example, I am seeing this object. When we see the object, the lines of sight of both the eyes, the line of sight of this eye, the line of sight of this eye will be intersecting on this object. And the image of this object will form at the fovea of both the retina. That is in the macular area of both the retina. This point you have understood. Whenever there is an imbalance of the extraocular muscles, you remember the extraocular muscles, superior rectus, inferior rectus, medial rectus, lateral rectus, superior oblique, inferior oblique. Whenever there is imbalance of these muscles, especially in the primary position, one eye is not aligned. So, one eye may not be aligned. One eye may not be aligned to the visual axis of the other eye, and this is known as strabismus, and in simple English, the squint. With strabismus, while one eye is fixating on the object, the other eye deviates in some other direction, either inward when it is known as cross-eyed, outward when it is known as wall-eyed, upward or downward. As a result, the person may either experience diplopia, that is the double vision, but means one object, he may see the object as two because of the misalignment of the two eyes, or the brain may suppress the image of one eye, that is the eye which is not fixating on the object. The brain may suppress that image, leading to the preferred eye, that is a fixating eye having a single vision, and the other eye turns into amblyopia because of the suppression later on. The angle of deviation of the strabismic eye is measured in prism diopters. And how is it measured? We have already seen using a prism bar test. So when the strabismic eye is aligned inward, it is known as esotropia. ESO. When the strabismic eye is moved outward, it is known as exotropia. Exotropia with X. When the one eye is in the primary position and the other eye moves upward, it is known as hypertropia. When the one fixating eye is in the primary position and the other eye moves downwards, it is known as hypotropia. So here is an example of a esotropia in a child. That is the inward movement of that is a medial alignment of the strabismic eye, and the child is fixating with this eye, and you can see the light reflects in the cornea of this child. What is the classification of esotropia? We all know that whenever we accommodate, it has three parts, that is the near reflex, the convergence, and the pupil meiosis. Whenever these three are the parts of accommodation: the near reflex, the pupillary meiosis, and the convergence. So the one of the causes of esotropia is related to accommodation causes. The accommodation which is used to see the nearby objects by the eye, it is a physiological mechanism. One of the causes of esotropia is accommodation. It can be either excess accommodation or less accommodation, we will see. And the other esotropia is classified as a non-accommodative causes in which accommodation plays no role. So the causes related to accommodative esotropia can be subclassified into refractive causes and non-refractive causes. In the non-refractive causes, it can be the convergence excess. What does convergence excess mean? Convergence excess related to the accommodation. For example, we have to see this object. For this, our full accommodation has to play the role that we have to converge the eye, we have to see this, the pupil will myose, and the ciliary muscles will accommodate. Ciliary muscles will accommodate. Accordingly, the lens shape will change. Okay, now if there is a convergence excess, for example, for this we have to accommodate this much. That is a normal accommodation, but there is convergence excess that the eye will move more inward relative to the accommodation needed for this object. It is known as convergence excess. Or there can be accommodation weakness. For example, for seeing this object we have to converge a bit, but the eye does not accommodate normally. That is, the ciliary muscle does not accommodate normally. It is known as accommodative weakness. For seeing this object, we will accommodate much more, and therefore it will appear as if it is a convergence excess, but it is actually accommodation weakness. So the non-refractive accommodative esotropic causes are convergence excess or accommodation weakness. The refractive causes of accommodative esotropia are in which there is a fully accommodative esotropia or there is a partially accommodative esotropia. That is, partially accommodative means it is related partially to the accommodation and partially to the non-accommodative cause. What are the non-accommodative causes of esotropia? They can be classified as essential infantile esotropia, as we saw in the essential infantile esotropia, as we saw in this image. Microtropia, very minor, about 4 prism diopters esotropia is known as microtropia. Basic esotropia, convergence esotropia, convergence spasm, where convergence spasm due to medial rectus. Divergence is insufficiency on looking at distance. Convergence spasm on looking at near. Divergence insufficiency on looking at distance, or divergence paralysis on looking at distance. Physiologically, whenever we look at a near object, our eyes converge, and whenever we look at the far objects, our eyes diverge. Eyes converge, our eyes diverge. Okay. The sensory esotropia, when the sensation of vision is, when the sensation of light or from the object doesn't reach the eye. Consecutive esotropia after the surgery for the exotropia. Acute onset esotropia due to some neurological causes, or a cyclic esotropia due to a neurologic cause. Exotropia, when the fixating eye is looking at you and the strabismic eye moves outwards, it is known as exotropia. We can see the corneal reflexes. Here the corneal reflexes has come in and the eye has moved outward. The classification of exotropia can be constant early onset exotropia in childhood, intermittent exotropia in which the eye moves into a exotropic, that is the outside position, whenever the eye is overstressed. Okay, whenever the patient wants to relax the eye from the work it is doing, the eye moves outward, and after some time the eye again moves in. It is known as intermittent exotropia. Remember, it is not latent strabismus. Okay, latent strabismus is seen only after breakage of fusion. Here there is no breakage of fusion, still the eye moves outward, and after some time again the two eyes are aligned straight, and this is known as intermittent exotropia, and this is generally due to anisometropia. Then there is a sensory exotropia in which one eye is amblyopic and with time moves towards the outside resting position. Consecutive exotropia is seen after the surgery for esotropia, when there is excessive correction. On the basis of fixation, strabismus can be classified into alternating and monoocular. What is alternating strabismus? In this, there is a spontaneous alteration of fixation from one eye to the other. For some time, for example, my right eye is fixating on this object and the left eye is strabismic. And for some other time, my left eye will fixate on this and my right eye will move into a strabismic position. It can be monoocular when there is a definite preference for fixation with one eye. For example, if my right eye constantly focuses on this object and my left eye is always in a squint position, that is a strabismic position, that is always lying outwards or inwards, it is known as a monoocular strabismus. On the basis of onset, strabismus can be classified into congenital and acquired. What is a congenital strabismus? We label the strabismus as being congenital when the deviation is documented before the age of 6 months. That is related to any defect present at birth. And the more appropriate term for this congenital strabismus will be the infantile strabismus. It can be acquired when the deviation has a later onset, that is after a period of a normal apparent visual development, it is referred to as acquired strabismus. Incommitant strabismus. Commitant strabismus is when the deviation angle remains same in different positions of gaze. In different secondary position of gaze, the deviation angle remains the same between the two eyes. What is incommitant strabismus? It is the strabismus when the deviation angle changes with the different gazes. We have already covered this in the previous video. And the incommitant strabismus, one of the reasons is the paralytic strabismus, in which the extraocular muscles are paralyzed. Either medial rectus is paralyzed, that is third nerve palsy, or a lateral rectus, that is sixth nerve palsy occurs. And the term paralytic strabismus is limited to the innervational causes of the restricted motility. Okay, but the incommitant strabismus includes both the paralytic strabismus and the restrictive strabismus. For example, some tumor. If some tumor is present, we will not be able to move the eye in that direction. So, the incommitant strabismus includes both paralytic strabismus and restrictive strabismus. Paralytic strabismus is limited to the innervational causes of the restricted motility. And the third nerve, fourth nerve and sixth nerve paralysis refer to the paralysis of the muscles supplied by those cranial nerves and not the actual paralysis of those nerves. It refers to the paralysis of the muscles of those nerves. If all the extraocular muscles supplied by the third cranial nerve are paralyzed, the paralysis is termed as complete oculomotor paralysis. And if even one or more extraocular muscle is not involved, the oculomotor palsy is partial. If all the extraocular muscles are paralyzed, it is known as external ophthalmoplegia. If all the intrinsic ocular muscles such as the iris muscles and this ciliary muscles are paralyzed, it is known as internal ophthalmoplegia. If both the extrinsic and the intrinsic muscles are paralyzed, it is known as complete ophthalmoplegia. So, the next cause of incommitant strabismus is mechanical restrictive strabismus, in which there is a structural alteration of the muscle itself or of its antagonist, and thus it may limit its ability to function normally and its action may be lost. Next, in the next video, we will study about amblyopia.